Hi guys. We will be talking about management of patients with dysrhythmias and conduction problems in this PowerPoint presentation. This is found in chapter 26 of your Brunner book, 14th edition, and it's on page 712 to 748. We will have a review of the conduction system of the heart. We will be analyzing the electrocardiogram rhythm strips and discuss some of the most common dysrhythmias and how to manage them. Um, if you read your objective for cardiovascular, you are not expected to interpret EKG tracings in Nursing 201. However, by next semester, you will be. So I guess my point here is as early as now you get to understand the most common or basic dysrhythmias and how to manage them. We will also be describing the different types of modalities um, for this arrhythmias and such as the pacemakers, defibrillators, and ICDs and its nursing implications. Okay, so before we proceed to the dysrhythmias, again, it's important to understand the electrical conduction of the heart. Yep, we're going back to anatomy and physiology. I have attached links here specifically about the electrophysiology of the heart and its and the action potential. They're pretty much the same thing, but so again, the cardiac conduction system is a group of specialized cardiac muscle cells in the walls of the heart that would send signal to the heart muscle causing it to contract. The right side of this slide shows you the main components of the cardiac conduction system. You have the SA node, the AV node, the bundle of His or the AV bundle. We have the bundle branches and the Purkinje fibers. Okay. So again, SA node, this is the anatomical pacemaker of the heart. It starts the sequence by causing the atrial muscles to contract. From there, the signal travels to the AV node, down through the bundle of His and down to the bundle branches and through the Purkinje fibers, causing the ventricles to contract. Okay, now the signal creates an electrical current that can be seen on a graph called the ECG or the electrocardiogram. Doctors and nurses use an EKG to monitor the cardiac conduction system's electrical activity in the heart. So again, why do I keep on repeating myself? Because it's really important to understand this anatomy. In two sentences, how does the conduction system of the heart do or work? Electrical signals arising in the SA node located in the right atrium. They stimulate the right or the atria to contract and they travel to the AV node or atrioventricular node, which is located in the interatrial septum. And after a delay, the stimulus diverges and is conducted through the left and right, a bundle of His to the respective Purkinje fibers for each side of the heart, as well as the endocardium at the apex of the heart. Then finally, to the ventricular epicardium. So know this system by heart because it's really important to understand the dysrhythmias. As I mentioned earlier, doctors and nurses and the healthcare providers, they use the ECG because it offers important information about the electrical activity of the heart, and at the same time, it's useful in diagnosing dysrhythmias. So ECG waveforms are printed on a graph paper, and they are divided into vertical and horizontal lines, as you can see in this picture. Um, uh, the time and the rate are measured on the horizontal axis of the graph, and the amplitude or voltage is measured on the vertical axis of the graph. So, um, why do I have to say this? Because it's important to know the different waves, complexes, and intervals of the different waveforms. So let me start with explaining to you the different waves and the waveforms of the ECG. So we have the P wave, we have the QRS complex, we do have the ST segment, the T wave, and the U wave. So in the R to R, I will tell you more about that if you want to determine the heart rate. So this is a very important part of the ECG, or the waves of the ECG. There are other waves that we need to that I don't need to mention. Like I said, right now this is nursing 201. We're gonna be starting with the basics. So know this, we have the P waves, the QRS, the ST, the T wave, the U wave. So again, we use the ECG because we want to diagnose, or we want to know the heart's electrical activity. Okay, so again, depolarization means electrical stimulation, and repolarization means electrical relaxation. Um, so remember that the P wave, which is normally the first sign of the electrical output, what does it represent? It represents the atrial depolarization from the SA node, and it's leaving to travel down to the AV node, and it's usually less than 0.11 seconds. Again, 0.11 to 0.12 at the most, or three small boxes. For the purposes of examination, remember 0.11. And that again, it means the atria is depolarizing impulse and is leaving the SA node, traveling to the AV node. Now, the QRS complex basically has the QR, it represents the ventricular depolarization. So the electrical impulses travels down to the ventricle, excuse me, um, and the electrical discharge is going to happen through the ventricle. The T wave shows a positive deflection, meaning it goes upwards, and it represents again which one? Our ventricle repolarization. So you look at this sequence on here, we're going to have a trio depolarization that occurs at the P wave, followed by the ventricular depolarization and then ventricular repolarization. Um, which is we're gonna have to have a normal rhythm. Uh, Followed by the QRS, followed by a T wave. Don't worry about the U waves yet. We're not talking about those in nursing 3. So our P is our, again, atrial depolarization. I keep on saying this. How many times do I have to say this for you to remember? QRS, ventricular depolarization, and then our ventricular repolarization. Um, Again, the thing that you really need to understand here, it's really important to note that if there's any abnormality of the P wave, there's something going on in the conduction system within the atria. And if there's something going on, or any abnormality with the QRS complex or the T wave, it is ventricular in nature, meaning the ventricular component of the electrical conduction system is wrong. Okay? So again, P atria, QRST ventricles. This will give you a link of what the waveform means. It's the relationship of your E. So how will we determine heart rate? Looking at the picture, heart rate can be obtained from the ECG rhythm strip by several methods. You have to remember that 1 minute or 60-second rhythm strip contains 300 large boxes and 1500 small boxes, or 1500 or 1500 small boxes. Okay, so you're looking at a strip A, you're going to count the number of small boxes within an R to R interval. or a P to P interval. It depends on which one you want. Remember, the P is your atrial depolarization. We're talking about P or atrial rate. And if it's an RQRS, we're talking about ventricular rate. So most of the time, we want to know more of the ventricular rate. So R to R interval, you have to find first where the first R wave component, either way, you can pick the second to the last R wave or the first R wave in the ECG. And then you are going to count the number of boxes between the first R wave you chose and the second R wave. So based on the strip A, the first R wave, if you look at that picture, it says R to R. The number of boxes between the first R and the second R is 25. All right, there are 25 small boxes. So you're going to divide 1,500 by 25, and it gives you an estimate of 60. That would be your heart rate, and that's the heart rate of this patient. But you gotta understand here that it's mostly applicable, or it's more accurate to determine this heart rate if we have a regular rhythm. So this strip A is an example of normal sinus rhythm. Sorry. Now, you can also use another way or method of determining the heart rate by looking at rhythm B. So this isn't another alternative, but it's less accurate method for estimating, estimating the heart rate. But normally it's used when the rhythm is irregular. So in here, you're going to count the number of all the R's, okay, intervals in 6 seconds, and multiply that number by 10. So usually in your ECG paper, it's marked it marks the 3-second intervals, which is 15 large boxes horizontally. So you don't have. So in here we do have approximately how many RR intervals? Can you count? Yep. So there are approximately 7 R to R intervals in this 6-second strip. So based on this strip, you're going to multiply 7 times 10. That will give you 70, and that would give you, again, its R is a atrial or ventricular. It's a ventricular heart rate. The ventricular heart rate for rhythm strip is 70 beats per minute. Okay, so it doesn't have to be the R. Like I said, you can also use the P wave if you want to know the atrial rate. So get a count the P to P interval in this rhythm strip, multiply it by 10, and that would give you an estimate of what the P or the heart rate. And obviously, as you can see in this strip, the strip is irregular in rhythm. So this is an example of a sinus arrhythmia, meaning everything is normal, just like your normal sinus rhythm, except for the rhythm. The rhythm is irregular. You can find in your Bronner book, page 717 or 717, chart 26-1. It gives you the interpretation of dysrhythmias, the systematic analysis of the ECG. So when you're going to examine an ECG rhythm strip, you want to learn more about the following criteria. And there's a 12 checklist to begin with. So for the purposes of nursing 3, as I mentioned, every now and then you are not required to read the strip, but you will be needing this by next semester. But then again, for the purposes of understanding the basics, you just want to make sure that you're looking here is the rate. I just talked about heart rate determination in the previous slide. So again, how do we do that? Just count the number of the R waves, multiply it by 10, and you'll get the ventricular rate. Okay, if it's an R wave, ventricular rate. If it's a P wave, then that would be what? Yes, your atrial rate. So it has the same thing as determining the rate multiplied by 10 the ventricular or the R to R waves, or the atrial rate, which is the P to P waves. Um, so next thing that you want to do is to look at the rhythm. Basically, is the rhythm regular or irregular? Again, the previous slide shows you a perfect example of a regular rhythm, which is your rhythm strip A, and your irregular rhythm, excuse me, which is the strip B. So one way to make sure, if you're not to make sure, or if you're not sure that the rhythm strip is regular, is I would take a piece of paper, a blank paper, and mark it from one R to the next R, or from a one P to the next P, and then you're gonna follow the same spacing, move it around. So if you would know that it is an irregular rhythm if they don't have the same spacing. Okay. Then again, I'm not going to make you measure the QRS or the P wave or the T waves. Basically, we just want to make sure right now that there are P waves and it is followed by the QRS. That's the most important thing. That the P wave is followed by a QRS and there's a T wave. That's the most important thing for you to know. Okay, so this is a good picture of the normal sinus rhythm. Remember, the electrical conduction that begins in the SA node generates a sinus rhythm. Okay, a sinus rhythm occurs when the electrical impulse starts at a regular rate and rhythm in the SA node and travels through the normal conduction pathway. So you want to know the rate, the rhythm, the QRS duration, the P waves, the intervals, and the ratio. But for nursing 3, as I mentioned, you are not you're not required to read ECG, but you're gonna know at least to identify most common dysrhythmias. So going back, sinus rhythm rate is 60 to 100 beats per minute in adults. The rhythm is regular. QRS shape and duration, they should be normal. Um, the PR interval should be between 0.12 and 0.20 seconds, and the P wave, it should be normal and consistent shape, and it should be always in front of the QRS. Okay, so remember with the sinus rhythm, we do have the rate of 60 to 100. 100. The rhythm is regular. The P is followed by the QRS. So with the sinus bradycardia is one form of the sinus node dysrhythmia. What you see here is you're going to have a rate that is less than 60. And the other components, the rhythm and other characteristics of a normal sinus rhythm, the sinus bradycardia has it too. The only difference is that the rate is lesser than 60. So symptoms wise, you're not going to see a lot of patients who will have symptoms or they will have no symptoms, because actually it's most of the time it's normal in them to have a bradycardia. Um, if they are symptomatic and there's a change from their baseline, what you see is that you might see these patients shaking as they might develop a hypotension or syncope, and sometimes a little bit of um, the confusion, decreased level of consciousness, altered mental status. You will see sometimes bradycardia as a normal rhythm, or a sinus bradycardia as a normal rhythm for patients who have or who are athletes or runner. So you don't need to treat that. Um, Patients who are on antihypertensive medications normally as well are going to have a normally lower than the normal heart rate as a result of the medication that they're taking. So you might see a patient who has sinus bradycardia uh, when they are taking medications such as your beta blockers and your calcium channel blockers. So what you can do is you're going to look at their history, look at these meds, look at if they are taking these medications, and it's normal. It's a normal expected finding of these medications. Um, if the patients are taking it. So also, you may want to look at your patient. Maybe they are bearing down because you want to make sure that they're not bearing down. Remember, when they bear down, they drop their pulse as well as their temperature. So you want to check on the temperature. When it's low, it can also lessen the heart rate. Also, conditions like hypothyroid patients, they normally have low heart rate. So what would be your treatment for this? Again, if they're asymptomatic, you don't need to do anything about that. They don't have any symptoms. The only time you can do something about sinus bradycardia is that when they begin having symptoms, such as signs of low cardiac output. So the treatment of choice here is you want to give zero point 0.5 milligrams of atropine, and you can get that every 3 to 5 minutes with a maximum dose of 3 milligrams. So if the patient is not responsive to atropine and they become more symptomatic, you're going to have to look at the other causes. Okay? Treat the cause. If they're taking all this medication, you can hold that. Inform the doctor, hey, doc, I'm not going to give my low pressor because my heart rate's this low. Stuff like that. Then again, if it's still not working, we might have to institute transcutaneous pacing. We're going to talk more about that in the next few slides. Our book can also suggest catecholamines such as dopamine, specifically if the pressure is really soft, or epinephrine. So those are the medications you want to give. And those are the treatments for patients who have sinus bradycardia. As opposed to your sinus bradycardia, sinus tachycardia, on the other hand, has a rate of more than 100 beats per minute. It is still sinus, which means it's regular. It has a P wave, only that the rate is more than 100. Our book says it has to be 100, but usually less than 120 beats per minute, either ventricular or atrial rate. Okay, so it's pretty much the same thing as your sinus rhythm. They're regular in rhythm. QRS is normal. P wave is always normal. The shape is it's a pretty much good shape. It's in front of the QRS complex. So, what are the signs and symptoms of patients with sinus tachycardia? So they can be anxious. Um, Sometimes they feel like they don't know that they're having sinus tachycardia as well. And most of the time, for really acute patients, why they're getting sinus tachy are your H's and your T's. So if you've heard about that, I'm sure with your BLS, you've heard about the H's and your T's, which are your hypoxia, hypercapnia, your acidosis, or your elevated hydrogen ions. You learned about that. Hypovolemia, also have your hypochloremia and magnesemia, hyperthermia. So those are your H and your S's, which is the stressors that, or the T's, I should say, which is our toxins, um, tension pneumo or pneumothorax, trauma, tamponade, and then some stressors and fever obviously can increase the heart rate. So basically, what can you do about that? I mentioned vagal maneuver earlier. What does vagal maneuver do? If you tell your patients to bear down, it's going to lower the heart rate. Other times, doctors will order beta blockers, and which are those? Your OLOLs. So they are given metoprolol or lopressors, atenolol. It depends who's ordering. They are also advised to take calcium channel blockers or diltiazem and verapamil most of the time. And if those things are still not gonna work, patients are advised to do ablation. So the thing that really the worst case scenario with sinus tachycardia is that as the heart rate increases, what happens here is the diastolic filling time decreases and cardiac output may be reduced. So again, with less cardiac output, we want to think about syncope, and we want to think about decreased blood pressure, which is your hypotension. And if this rate persists, the heart cannot compensate anymore, and patient could also develop pulmonary edema aside from heart failure. So you want to make sure you treat the cause for sinus tachycardia. So again, figure out what the cause is. You want to treat the cause and get rid of it. Okay, so for the supraventricular tachycardia or SVT, it's a tachycardia that's greater than 180 beats per minute. So usually the P wave cannot be identified. When you slow down your rhythm, it's gonna show you a little bit of an AFib or a flutter, but basically it's just shows you a very, very, very fast rhythm. So signs and symptoms of this would be patients are going to be really anxious because they feel that their heart rate's like pounding really, really fast. And obviously you'll see that EKG or the monitor shows more than 180. So what would be our interventions for this? As it's pretty much the same thing as I say with the sinus tachycardia. You want to stop whatever the cause is, but you want more immediate management for this. So we can start doing the vagal maneuvers, such as we have, as I mentioned earlier, you want to do the bearing down, or like the patient is having a bowel movement, you want to do the carotid sinus massage. You also want to do some gagging. You want them to give them a big cough. So I always tell my patients, give me a big cough whenever I see these kinds. Also, cold stimulus or a stimulant by immersing the face in ice water. I'm not sure, but if you guys are watching The Resident, so I love watching that show. Sometimes it's not real, but there's this incident about an SVT, so where the doctor actually pour a big pail, not a pail, but a big uh basin of ice and just toss it out the face, and it helped out. So those are your vagal maneuvers. Also, second management, if vagal maneuvers don't work, you want to start with adenosine. So for the adenosine, um you want it really, really fast, so you want to give 6 milligrams of adenosine IV push. Sometimes I always make my not sometimes, but I can't even say. I raise the patient's arms right away if it's in a peripheral IV, so it goes straight down to the heart. The half life is really, really short, so it happens really quick. And you want to make sure you push it with 10 to 20 mLs of saline flush. So that's for the adenosine. If it's not going to work still, then we can do cardioversion. So basically you just want to make sure you do everything aside from knowing what the cause is, the H's and the T's and all that. These are your treatments. The complication here at the same time, always a problem with dysrhythmia, is the cardiac output. So you know all your signs and symptoms for low cardiac output. This is not so good kind of dysrhythmia, so you want to make sure you stop the rhythm, do a cardioversion as quick as you can, and give all the medications that you need to give. The next slide will give you a really good example, a real life scenario of managing SVT.